At that point, I was diagnosed with interstitial cystitis. Later on, I got several other diagnoses like pelvic floor dysfunction, pudendal neuralgia, and then actually during my doctoral degree, Crohn's disease, and all other sorts of fun things. And so, as I was developing as an academic and counselor, those experiences were intertwined with that development and influence. So, I would say college was the most challenging for me because I was new to this. I was very invested in being a successful student. I got into disability services and got accommodations during college, which were tremendously helpful. I think that piece of paper is very powerful for better and for worse in academic institutions because they don't want to get sued. And although they should have more reasoning than just cover your ass, right? They should have more reason than that to provide these accommodations, but sometimes there are professors or supervisors who that's it. So that's where that piece of paper comes in handy.
Hello, everyone. This is Dr. Moss at Life as a Patient Doctor podcast. I am very excited to interview Dr. Brittany Hudson, who's a PhD and LPC, which is a licensed professional counselor in Texas. She earned a degree of science in psychology with a minor in biology from the University of Texas in Austin. She later earned her Master of Science in Clinical Mental Health Counseling and a Doctor of Philosophy in Counselor Education and Supervision from the University of Texas at San Antonio. She completed her qualitative dissertation research titled Private Parts, a heuristic inquiry into the relational, cultural experiences of chronic pelvic pain. Brittany is currently focused on counseling practice and advocacy. Her specialties include chronic pain and illness, obsessive compulsive disorder, and traumatic grief. She also volunteers with Tight Lift, a grassroots movement by and for people with chronic vulvovaginal and pelvic pain. Thank you so much for being here.
Thank you for having me.
I am excited to learn more about your journey, especially in this field of clinical counseling.
Yeah, so I guess I should start from the beginning. I would say that my journey into counseling started in childhood. I always had an interest in people's internal world. As I got ready to go into college, I knew I wanted to pursue psychology, but for various reasons, I was convinced to add in pre med to that. So I, for a while, was pursuing medicine. I was interested in going into psychiatry. I took all the pre-med requirements, took the MCAT, shadowed doctors, volunteered, all of those things. I got waitlisted to a graduate program in biomedical sciences and didn't get off the waitlist. When I didn't get off the waitlist, I felt really relieved. And I was like, what's this about? Why do I feel relieved to not be pursuing medicine? And it was at that point that I found myself back at where I started, basically, which was okay, I actually want to be a therapist. And a lot of the things I really loved about medicine had to do with bringing the humanity there, bringing that human relationship into medicine. Ultimately, I was like, I don't want to work that hard at that, but I do want to work that hard to pursue counseling. It's all already there. That's the core of counseling. And so it ends up being a good fit.
I love that. What a journey, and how interesting that you were interested in medicine. I think that is such a common thing that
Mhm.
in undergrad, we're almost pushed towards like medicine's the only way. And there's so many other ways to help people, especially when you talk about mental health. I recently interviewed a social worker who just did her master's, and she was telling me about all these other paths that I had no idea. What led you to this specific version of counseling?
I knew somebody who was a counselor. My only exposure to mental health was through that person. And so I really only knew about licensed professional counseling in Texas. It wasn't until I got into my graduate program that I knew about the other paths. And I have a lot of respect for school psychologists, social workers, and in particular social workers because they do a lot of advocacy work. Through that exposure, I think I'm able to incorporate some of those concepts into counseling that are newer to our field.
That's a really good point. I never thought about padding in that advocacy component. Talk me through a little bit about what different challenges you had during your graduate level education.
Sure. To the point of your podcast, which is My Life as a Patient Doctor, I'll talk a little bit about being a patient myself. When I was in high school, after years of recurrent urinary tract infections, kidney infections, ovarian cyst ruptures, all the fun adventures of my adolescence, I started to have a lot of urinary frequency to the point where I was leaving my classes multiple times per period, which doesn't really work with the whole system. Right before college, the summer before college, I went to a urologist. The diagnostic testing they had for my condition was very limited and actually quite painful. I had a cystoscopy where they inserted a catheter and put in a saline solution and something with potassium. If the potassium hurts like hell, then you have something called interstitial cystitis. It hurt like hell. At that point, I was diagnosed with interstitial cystitis. Later on, I got several other diagnoses like pelvic floor dysfunction, pudendal neuralgia, and then actually during my doctoral degree, Crohn's disease, and all other sorts of fun things. And so, as I was developing as an academic and counselor, those experiences were intertwined with that development and influence. So I would say college was the most challenging for me because I was new to this. I was very invested in being a successful student in a way that's different than how I see myself now. But unfortunately, with my symptoms, I would have difficulty sleeping at night. And so I would sleep during the day, miss a lot of classes, and so on. I got into disability services and got accommodations during college, which were tremendously helpful. Then I went into my master's degree about a year after I graduated college and decided for myself, I don't need accommodations. This is going to be totally fine. At the time, I had a neurostimulator implanted and it was helping with symptoms, but I certainly wasn't in a place where I was pain free or flare free. Graduate school for my master's degree in counseling was challenging. I'm trying to be a present clinician. I'm trying to be reliable and consistent in all those things. And then sometimes my illnesses would get in the way of that. And I'm trying to figure out what does life look like as a counselor with chronic pain and illness. But nothing came up academically. The same thing that I had in college where I was missing classes and not making good grades for the first time in my life. Where it got really hard was during my doctoral degree, which was, of course, more stressful than a master's degree. My first semester in my doctoral program, I still didn't pursue accommodations because I was delusional or something. And I had difficulty turning in one assignment. It was impacting me academically and therefore emotionally. I finally got back into the Disability Services Center and got those accommodations, which were a lot more helpful throughout the program. In terms of how that was challenging, there's so much placed on this idea of being productive because academia is intertwined with systems like capitalism, neoliberalism, ableism. The challenge was unlearning the ideas I had based on those systems and crafting this space for myself that was rooted in more resistance and authenticity. And I think I finally got there, but not until I defended my dissertation.
Oh my goodness, yes. Something that really stuck out to me is the journey of accepting accommodations, not accepting
Mhm,
accommodations, seeing yourself as someone who has disabilities, not. I very much resonate with that
mhm,
in a society, especially academia, like you said, that there is this concept that you have to be perfect. You have to have the best grades. In medicine, we talk a lot about the complete separation of any type of human need or human struggle, especially when we have needs that are consistent, are there day to day and impacting us physically, emotionally, academically. You said the concept of learning how to be authentic. When did that shift or how did that shift?
I think in a lot of ways that shift happens out of necessity when you're so entrenched in these systems and place your own value on what you can produce. It's a very dehumanizing experience. And it's also, at least for me, very antithetical to my values. I think I just got to this place where I was in a bit of a crisis of identity and what is this all for and who am I? What do I value? I think at a certain point, I started to dip my toes into this idea of I'm going to make decisions based on my values, who I am as a person, rather than pleasing people or adding something to my CV. As I started to do that, I noticed how it felt. Just like with not getting off the wait list for the biomedical sciences program, I checked in with myself and I noticed this feels really good, actually. Once you say no one time, I'm going to keep saying no because this feels right for me. And because of that, I was able to pursue only those opportunities that made sense for me. So, one of those being volunteering with Tight Lipped. I set that intention for myself before I even graduated my doctoral program that I'm going to take off Mondays. I'm not going to work on Mondays because I don't want the Sunday scaries, but also because I want to set aside that time to be involved in things that matter to me that maybe don't get me into a tenure track position or don't get me the recognition at a conference, but they are meaningful to me. I think how that shift occurred was gradually by seeing the benefits and the wholeness I felt by no longer engaging in those systems.
That's beautiful. And I love that you said learning to say no. I think that
Mhm.
is one of the most challenging, but important and meaningful things that we can do as students, as individuals with disability, with health conditions. We don't have to say yes to every single project, every single person that needs us. We need to learn to really look inwards. I love that you mentioned tight lipped because I think that's actually where we first connect is both of us being volunteers. And I'm interested on how you've worked with them. What have you done with them? What, for those who don't know tight lipped, I know we talked about it a little bit in your bio, but could you speak a little bit more on it?
Sure. So, as part of my dissertation research, I actually invited the participants, or what I called co researchers, to share a creative depiction of their experience. That could be like songs, artwork, poems. And there was actually one co researcher who shared several excerpts from the tight lipped zine called Opening Up. And yeah, I'm sure you have it right there. I have it on my desk back here. And that was really my first introduction to tight lipped. And I am really into punk and the DIY ethic and whatnot. And to see a zine focused on the same topic that was my dissertation research, but also that is my living experience, I was like, this is so cool. So I started looking into it. Tight lipped, for those who don't know, is the first and only national movement by and for people with chronic vulvovaginal and pelvic pain. They do various advocacy efforts and campaigns. Right now, their campaign is focused on incorporating chronic vulvovaginal and pelvic pain into residency programs. And when I found Tight Lipped, they were primarily in the Northeast and the West, but not in the South. Importantly, not in the South. I actually reached out to the director and said, hey, I'm really interested in this. I thought I was wrapping up my dissertation research and I would love to get involved whenever I graduate. We started that relationship a year before I defended my dissertation. And once I did finally finish, I was able to get connected again. Now we're starting the work to begin a chapter in San Antonio. That's where we are right now. I definitely thought it was something needed in the South, given our current political climate and our healthcare system here. I thought this is something we certainly need down here.
I'm so glad you found the group and used the information to impact your dissertation and publish it. I started reading it last night a little bit when you sent it to me. I'm like, oh my goodness, I'm so excited to talk to her more. And you mentioned the design. I know it's somewhere in my bookshelf. I'll share it below, but I have a section on my website called support groups for people with pelvic pain. I'm so glad that we have individuals with so many diverse perspectives who are patients, but can bring that information to others. I'm interested because in your bio, you talked about working with clients who also have pelvic pain or pelvic conditions. How did
Mhm.
that cross over?
I think a lot of counselors share in this with me, but I am very driven to provide support to people who have gone through similar things that I have. It was rooted in my experience of chronic pain and illness, but also just knowing how uh, unavailable and inaccessible basic validation and support is to people with chronic pain illness, especially to people with chronic vaginal and pelvic pain. There is this sense that it is a private part, a secret experience. I realized that I could offer something to clients that maybe they don't find with other counselors because of that connection. I found that incredibly rewarding in my work.
That's beautiful. I love that. It's definitely something that I hope to do also in the mental health field as a psychiatrist is work with other people with pelvic pain. I'm interested to hear your perspective on disclosing to patients that you share a similar or not disclosure. Like, how do you navigate that experience?
So, in counseling, and particularly in the theory that I primarily operate from called relational cultural theory, there is this idea of therapeutic disclosure. The notion there is that disclosure can and often is appropriate when it's done intentionally and with this sort of anticipatory empathy with the client of how they might respond and how they might benefit or be harmed by such disclosures. And for me, I think there are a lot of benefits to sharing that experience with clients. One is just that sense of community. Two is the idea that this is something we can talk about. Even in just saying, I have chronic pelvic pain, there is this notion that, okay, my therapist has pelvic pain, maybe even has genital pain, and this is something we can talk about here. Implicit in that, this idea that I have insider knowledge into what it's like to navigate healthcare as well, and can provide empathy, but also practical suggestions on how to self advocate in those spaces. And so, because of that, I have included in my bio on Psychology Today and on our group practice website that I do have chronic pelvic pain. I don't go into depth there, but it's just this little signal that, hey, I get you to some extent and I'm ready to talk about it. And so I think in my bio, it says something like, as a counselor with chronic pelvic pain, I really enjoy seeing clients with this experience. I also disclose it briefly in my informed consent processes because it sometimes impacts my attendance. So I do want clients to understand if I cancel on them last minute, it is not because of them. Use that as a rationale for why I'm quite flexible with clients and their attendance too. I say something to the effect of, because I have chronic pain and illness, sometimes I have to cancel last minute. And therefore, I try to be flexible with clients too. I explain my policy. And so it doesn't have to be this lengthy disclosure or sharing my entire story, but just these moments where you can say, hey, I'm a human too. I'm connecting with you, especially if they also have chronic pelvic pain, that we're in community with each other in the context of this professional relationship. So I disclose.
Thank you so much. Those 3 points you gave were so meaningful. That was exactly what I wanted to hear. Someone who's been in the profession for a while and has disclosed successfully and has demonstrated the positive impact of it. I recognize that it can impact my judgment in a positive way. Working with you provided so many ideas that I will definitely include for myself in the future.
Yeah, without making it about yourself, which I think is often the concern people have about disclosure in general, especially within counseling, is you don't want to shift the focus to yourself. And I think there's plenty of ways that you can do that. With something like chronic pelvic pain, it's not apparent, but there are plenty of disabled people where their disability is apparent and they don't have a choice to disclose. I also find it a little odd that this is even a controversy in the field because it's just another disability. No.
Oh, I'm glad you mentioned that. The difference is if it's something like seeing someone in a wheelchair, they can't
Mhm.
hide that.
Right.
I talked with another therapist, PhD. They mentioned their race. If I am an African American Black individual and I walk in, as long as they have the visual capacity to see, they're seeing that I have this race and they can assume I have these types of experiences or connections based on their race. Similarly, they will know that I will not have experiences with being white or Caucasian. All of those are things that are not said in words, but patients and clients are still receiving from their
Yeah.
healthcare provider or mental health counselor. I love that. That was perfect. Thank you so much for sharing that. Have you had any negativity with a patient or a client for disclosing?
No, I would say any negative experiences I've had with it in the past were actually a result of not disclosing. When I'm canceling multiple times because I'm having a pain flare or medical emergencies, and at that time had internalized this idea that we don't show that side of ourselves to clients, then all clients are left with is their assumptions, which uh, can certainly lead them to a place where they're feeling abandoned or like my cancellations are something about them. I think any negative responses I've had in the past were actually a result of non disclosure rather than disclosure. I think that's something for people to consider. If you're not giving clients this information, what information do they have left, and what might that mean for them?
That's a really good point. Thank you for saying that. I didn't even think of that, but yeah, it can be seen as something like, oh, my therapist doesn't care about me, or my therapist doesn't
Mhm.
want to be with me. It can be painful. I can just imagine if that was happening to me, but having chronic pain myself, having to cancel my own classes, it's definitely something to think about.
Yeah, absolutely. And that's not to say that clients will not be frustrated, annoyed, or disappointed. I think those are understandable responses when you have an appointment and you have things you need to share and you're not able to that day. I think those are still understandable responses, but it does provide some relational context for them that does impact the counseling relationship and facilitates the repair of that rupture that might occur in those moments.
What about since you put it on your bio, how has your colleagues or work environments seen that disclosure?
It's been positive for the most part, to my knowledge.
Amazing.
Yes, I think by and large, the counseling field at its best is inclusive and open to what I see as a form of subversion and resistance, which is saying, yes, I am a human. Yes, I am dealing with this type of pain, particularly with vaginal or pelvic pain. People have been, at least where I'm at now, shout out if y'all are watching. Uh, people have been very supportive. For example, I have a cushion underneath me right now. There is no pressure to see a certain amount of clients, which was important to me when I was choosing a practice to work at. Some practices will require you see 30 clients a week, which is a lot for counseling. Here, there's a lot of flexibility. I come in a little later because I get drowsy while driving if I come in too early because I don't sleep very well. So I'd say by and large, it's been positive in workspaces. It was also helpful during my graduate program. Even though I wasn't registered with student disabilities, I did inform my internship sites that this is something I have, and it would be really helpful if I could come in at this time or sometimes take breaks or stand up because sitting is one of the harder things for me. And they were also very accommodating and helpful. I know that's not everybody's experience, so I do recommend getting registered with disability services for that reason. But thankfully, people have been very accommodating for me in that regard.
I'm so glad to hear that. Thank you for providing specific examples of things that you've done to help yourself manage your own work environment. We say get accommodations, but it's hard to have ideas of what has worked for other people. That is helpful also for me going into residency. I'm in the process right now of applying for accommodations at my new work.
Yeah, I think that is a challenge with pelvic pain in particular, is figuring out what accommodations are helpful. Uh, a lot of it is more of a way a space can be, which is hard to quantify, especially on a list of accommodations. I was really grateful for the disability office during my doctoral program because they were familiar enough with my conditions that they were able to suggest a list of things, and some of them I didn't use and some of them I did. It was things like being able to stand up, which I absolutely did sometimes in classes that are 2.5, 3 hours long sometimes. Being able to go use the restroom, which in a doctoral program, they let you use the restroom during exams because they didn't want you to go cheat in the bathroom. So that was actually really helpful in college. But it wasn't necessary in a doctoral program. They're like, yeah, go use the restroom. You're an adult. But also flexibility with attendance policies, extended deadlines, and then, of course, like the basic stuff, like extended test time. And I didn't always use it, but it was helpful when I needed it. And I think that's the basis of accommodations that I had to learn for myself, which is it's not saying you have to use these all the time, but they are there if and when it does come up.
Yes, so true. Yeah, that is definitely important to vocalize that they're just there if you need them as additional support. You don't have to use
Exactly.
them every day. You don't have to use them at all, but it's better to have something there if one day you have a flare or a day that you need a little bit more help and
Right.
support. I know for me, it's also helped manage when I have a supervisor that isn't as flexible, then I have a little bit of this is the accommodations I need from the disability office. Here, you can get more information there. It gives you a little bit more power when it's difficult to advocate for yourself.
I think that piece of paper is very powerful, for better and for worse in academic institutions because they don't want to get sued. And although they should have more reasoning than just cover your ass, right? They should have more reason than that to provide these accommodations, but sometimes there are professors or supervisors who that's it. So that's where that piece of paper comes in handy.
I created a blog post that kind of helps individuals navigate trying to get accessibility and accommodations in an academic environment or work environment, and then links to places like Docs with Disability. You can actually click through your specific disability. And I was surprised they had one for chronic pain.
Ah,
Looking specifically on the chronic pain, be like, okay, which ones would I need or which ones could I need? So that is helpful.
Oh, that's wonderful. I'll look into those too.
Yeah, I'll make sure to send it. It's Ask Something. It's from the ADA. They do a good job of going through chronic pain. So I was like, oh, good enough for now.
I will take it for now.
Yeah, they don't have endometriosis either. So little by little, right?
Mhm.
I know they do have Crohn's disease. That one is a more common one. Okay. As we start to wrap up, is there any other advice or pearls of wisdom you have for students or health professionals or mental health professionals who also have health conditions?
I think a lot of the work of finding yourself as a student or counselor with chronic pain and illness or with chronic pelvic pain in particular is first learning about ableism and how that intersects with other systems of oppression. And second is unlearning those things, because I think a lot of the emotional and social pain I have endured is rooted in those ideas that I had about myself, how I'm supposed to show up as a professional, how I can show up as a professional, and where I've found a lot of my joy is in just the kind of day to day resistance of just saying to a friend, my vulva hurts today, incorporating that identity into my professional bio and informed consent. In all of those ways, I think I've finally found a space for myself that feels much more authentic and joyous and free. So that's what I would encourage people to do. There are a lot of great books out there that talk about it. I think the most influential one for me, and I'm pretty sure it's a textbook, but it's just called Feminist Disability Studies. I believe it's by Hall, and I referenced that a lot in my dissertation. But there are a lot of good writings in there by different authors on various aspects of chronic pain, chronic illness, disability in general, and all those other systems that intersect with it.
Those are beautiful. I'll make sure to include that book. I haven't heard of that one. I have a list of different books broken down by pelvic pain and mental health, but that will be perfect for the pelvic pain. And then I quickly looked it up. It's Ask Jan because
Oh, okay.
Jan is Job Accommodations Network.
Oh, that's neat.
AskJan.org. And it literally has A to Z of all these different disabilities or health conditions. It is really helpful when trying to figure out what could exist for accessible accommodations or something you can ask your HR department or accessibility office. Thank you, Dr. Hudson, for your wise words and your vulnerability in sharing your story. I like to finish off by just summarizing all the things that you said. You were really interested in mental health, but also pre-med. You went through the pre-med track, but through the life circumstance of being waitlisted, you realize that maybe it felt more authentic being a counselor and
Mhm.
supporting others in that way. You went through your graduate studies, your master's, your PhD. Through that academic experience, you were diagnosed with physical health conditions, chronic pain conditions, and went through ups and downs of sometimes choosing to go with accommodations, sometimes not, because it was difficult to identify with that need in a society where it is so focused on productivity and being perfect. And you eventually came to really identifying your identity, your values, and found how you can be authentic in your own form. In your own client practice, you work on intentional disclosure all the way from before you even go face to face with the patient. It is on your bio that you have pelvic pain and you love seeing patients with the condition. You even talk about it during your informed consent, that you are flexible with attendance and you ask that they be flexible with you because it is part of the health condition. Sometimes you can't always know what days you need to take care of yourself. You also talked about how successful it's been to work with your own colleagues and work environment to be able to request accommodations, cushions for chair, taking breaks, numbers of clients. It's been really helpful in order for you to provide the best mental health care for your clients. Lastly, you provided some wonderful advice on how to unlearn the systems of ableism and oppression, and maybe changing the dialogue of what it means to be a professional yourself, and learning how to be authentic and caring for others. So, really navigating that bridge of being a person and a mental health care provider. So, I want to thank you so much, Dr. Hudson. If anyone, whether that's a client or another healthcare practitioner, how can they find you or get more information about your work?
Professionals, you can find me on LinkedIn. Potential clients or anybody who would like to connect with me as a counselor can also find me on Therapy Den, Psychology Today, all your main directories. Thank you so much. I really appreciate the opportunity to connect with you and to talk about these experiences. And thank you for all the work you're doing with
Oh,
this podcast.
thank you. And I'm also thinking, one, I'm like, do you take clients over state lines, or is that, I know there was a weird thing during COVID that sometimes you can, sometimes you can't. What
And
is the current mental health rules for that?
so they're working on an interstate counseling compact. Texas is not on that at this time. Right now, I am licensed to see clients in Texas.
If anyone's in Texas, you definitely want to get in contact with her. Having a therapist that understands my own health conditions, that would be amazing.
I can certainly try to connect you with some people with lived
That'd be
experience in the
amazing.
area
Yes,
if you'd like me
please.
to.
Maybe I'm thinking, when I'm a practicing psychiatrist, I'm hearing a really good person to send for patients.
Thank you.
Psychiatrists need therapists to work together. So
Absolutely.
thank you so much for being here. I also like to end all my podcasts and remind everyone that no matter what challenge they're going through, you are not alone in your experience, especially with health conditions and conditions like chronic pelvic pain or vulvovaginal pain. It feels very alone because it's not talked about. When things aren't talked about, when they're taboo, we feel very alone in our experience. I really hope that this podcast will remind you that you are not alone, and that you can form that community. Hopefully, seeing these interviews with other healthcare providers who have been able to keep going, and despite their different challenges personally or professionally. So I hope that is helpful for you. And if you aren't subscribed, subscribe on YouTube or on anywhere you get your podcasts. And you can follow me to get more information about living with disabilities, living with chronic pain, or as a patient or as a healthcare provider at medpsychmoss.com. You can follow me on social media at medpsychmoss. I look forward to seeing you all next time. Thank you again, Dr. Hudson.
Thank you.